Hey guys, welcome to Dogshala. Today in our topic, we are going to see about nephritic syndrome, which is a NEET MDS recall question also included in this video. So let's just dive into the topic. So what is a nephritic syndrome? Nephritic syndrome is characterized by inflammatory process of the glomerulus of the kidneys. Okay, so it is defined as the presence of one or more of the following. So the following things, if they are present, then it is characterized as nephritic syndrome. Hematuria with acanthosis, RBC casts in urine, proteinuria, that is proteins in urine, hypertension, mild and moderate edema, sterile pyuria, oliguria, or azotemia. It is most commonly associated with children. In children, 2 to 7 year old boys are most commonly affected. Adult nephritic syndrome can also come, but it comes as a comorbid situation with other diseases. Okay, so glomerular inflammation is the hallmark of nephritic syndrome. So this is the hallmark of nephritic syndrome. You have to remember this. This may be due to inflammation of the small vessels within the capillary tuft, that is vasculitis, immune complex deposition, or formation of anti-glomerular basement membrane autoantibodies. So this glomerular inflammation may be occurring with three reasons. One may be vasculitis, that is small vessel inflammation, immune complex deposition, or formation of anti-GBM autoantibodies. Okay, so this is what is nephritic syndrome is, and how it what is the uh, pathogenesis, like brief pathogenesis behind it. Okay, so let's just dive into the details about this. So let's just dive into the pathophysiology. So pathophysiology, as we have seen, the first important thing that we have to consider in nephritic syndrome is glomerular capillary damage. How it is done? In general pathophysiology, inflammation followed by cytokine release leads to glomerular capillary damage. Okay, then porous glomerular basement membrane which is present, it leads to leakage of proteins and RBCs, which leads to nephritic sediment. So this is the general pathophysiology. Then there is one more thing, that is membranoproliferative glomerulonephritis. So membranoproliferative glomerulonephritis is characterized by deposition of antibodies between podocytes and basement membrane. Podocytes and basement membrane. You remember your glomerular structure, right? So it will be having podocytes. There will be basement membrane. So the deposition of antibodies between these two will lead to membranoglomero membranoproliferative glomerulonephritis. It is of two types. Okay, type 1 and type 2. Type 1, what happens is subendothelial immune complex deposits are deposited, which leads to activation of classical complement pathway, which leads to cell injury, mesangial proliferation, and matrix expansion. Okay, so type 1, subendothelial immune complex deposits happen, which leads to activation of complex classical pathway, which leads to cell injury, mesangial proliferation, and matrix expansion. Then type 2. Then type 2, what happens is intramembranous deposition of complement C3. C3 is also known as nephritic factor. Intramembranous complex deposition of complement C3 leads to type 2 MPGN. Membranoproliferative glomerulitis, its abbreviation is MPGN. Okay, so which leads to activation of alternative complement pathway. When you have this thing like antibodies involving complement pathways involving, then you will come to a conclusion that it is an MPGN. Okay, so this is the pathophysiology of nephritic syndrome. Then, so this is just a picture depicting it, the general pathophysiology. So deposition of immune complex immune complexes or antibodies triggers inflammation. This is for MPGN, glomerulonephritis pathophys. Okay, so an inflammation injures the cells and degrades the GBM. So immune or quasi-immune mediated etiology is primary, acute, or secondary, acute or chronic. So RBC leaks into urine. Okay, so this is the thing. Then coming to the clinical features. So as you can see in the image below, these are the basic clinical features that appear in the nephritic syndrome: hematuria, blurred vision, hypertension, oliguria, azotemia. Azotemia is abnormally high levels of nitrogen. Okay, proteinuria, protein in urine. Oliguria is absence of low urine output. Okay, so let's just see. Intermittent or gross hematuria leading to red or brown colored urine, that is cola colored urine. Cola colored urine is seen in nephritic syndrome. With, already we have told hypertension. Pitted edema. Pitting edema is seen. Swelling of eye sockets, legs, arms, hands, feet, abdomen and other areas. So you have to remember this. Okay. Face, eye socket, legs, arms, hands, feet, abdomen, and other areas are swelled up. Okay, so in decreased GFR, that is glomerular filtration rate, oliguria, and uremic symptoms may be seen in this. Okay, then what are the diseases associated? That is nephritic syndrome. Syndrome is a cluster of diseases, right? So what is it? Let's see where it is associated, where and all, in what all diseases this nephritic syndrome can be appreciated as post-streptococcal glomerulonephritis. Okay, then Burgess disease, this is important. Burgess disease, you can see nephritic syndrome. It is a IgA nephropathy. It is IgA mediated nephropathy. It is most common cause of idiopathic nephritic syndrome. Then small vessel vasculitis. In small vessel vasculitis, in what all diseases? Granulomatosis with polyangiitis, microscopic polyangiitis, eosinophilic granulomatosis with polyangiitis. That is Churg-Strauss syndrome. Churg-Strauss syndromes cause small vessel vasculitis. Okay, small vessel vasculitis, which leads to formation of nephritic syndrome. It is the least common type of small vessel vasculitis. Churg-Strauss syndrome is the least common type. Then Goodpasture syndrome is an anti-GBM antibody disease which leads to nephritic syndrome. Basement membrane nephropathy, that is benign familial hematuria. Alport syndrome, diffuse proliferative glomerulonephritis, rapid proliferative glomerulonephritis, and membranoproliferative glomerulonephritis. So this slide is very important. You have to by heart what these diseases, and so that you have an idea where and all you can see the nephritic syndrome in patients. Okay. Then coming to the diagnosis. So diagnosis, as you know, first of all, we have to analyze urine. So urine analysis, nephritic sediment is seen, hematuria is seen, that is blood in the urine is seen, RBC casts are seen, and proteinuria of more than 150 milligrams per 24 hours, but less than 3.5 grams per 24 hours. Okay, the range is 150 milligrams to 3.5 grams proteins. Okay, acanthocytes and sterile pyuria, and sometimes WBC cast may also be seen in the urine. Then coming to the blood test, you can see increased creatinine and decreased glomerular filtration rate, azotemia with increased burn, and complement ANA, ANCA, and anti-GBM antibodies may be seen. And renal biopsy, it is not quite commonly indicated, but it is indicated when patient is presenting with a non-specific disease pattern. Then treatment. The treatment is supportive therapy. In supportive therapy, we have to advise a low sodium diet, and water restriction also should be advised. Medical therapy, if proteinuria or hypertension is present, ACE inhibitors and angiotensin receptor blockers are given. If severe hypertension and edema are there, diuretics. Okay, immunosuppressive therapy. If there is an immune system complex compromisation, then if rapidly proliferative glomerulonephritis from anti-GBM antibody disease, then plasmapheresis is advised. Then severe renal insufficiency or kidney failure, we can go for a replacement therapy. Okay, so proteinuria and hypertension, you have to be ACE inhibitors, angiotensin receptors, diuretics, and immunosuppressive therapy, and plasmapheresis in rapid. Okay, then MPG in type 1 and type 2 RAS inhibitors are given. Okay, and prednisone alone or in combination with other immunosuppressants such as cyclosporin or tacrolimus. So these are the medications which we can use in nephritic syndrome. Okay, so let's just see the question which was asked in NEET MDS 2023. It was a case-based question. The question is, a 6-year-old male child had a 1-week history of swelling of the extremities and around the eyes. So 1-week history is there and is a 6-year-old male child. So we know that it is nephritic syndrome is prevalent in the 2 to 7-year-old boys. So his mother observed blood in urine, that is hematuria. The child is suffering from. So nephritic, nephrotic. So the main difference between nephritic and nephrotic syndrome is the presence of blood in urine is seen only in nephritic syndrome. Okay. So these both are ruled out because of the symptoms. No way matching. So the most commonly matching symptoms are present between nephritic and nephrotic syndrome. The most distinguishing here is the presence of blood in urine. So hence the answer will be nephritic syndrome. Okay. So if you like our video, do like the video, subscribe and share it to your friends. And you can also follow us on our Instagram handles at Dogshala and at Dogshala Medical for medical content. And we are also there in Telegram. You can also find us on WhatsApp. So don't waste your time and prepare happily. Thank you.